still showing up the taskbar. Let's see if we can get rid of that. Nope. All right, well, I guess today we get to look at my entire bar of random stuff that's up on my computer. That's fine. I hope you all had a safe trip in. The ice has been interesting, to say the least. Just trying to think of a couple of things I wanted to talk about. I brought the midterms today, so if you wanted to go through those after class, then you are able to do that. Because I can't remember to send out an announcement to save my life. I'll also be bringing them on Tuesday next week as well, because I can just leave them in my bag and that's fine. I'm still working on the written assignments. I've also had it pointed out to me that 2 of our in-class recordings, the microphone kicked out halfway through or earlier. So I'm going to try and re-record those this weekend, and then I'll finish up the grading after I've done the recordings. So sort of time management on that part, but both should be done by the weekend or by the end of the weekend. So sorry for the delay there. There's just a lot of things that keep going wrong, but so I'll get those back and I'll correct that recording so you guys have that to study from. But otherwise, we're going to finish up chapter 14 today, and then that leaves us with just one more chapter to cover next week. So we are right on schedule, which is really, really nice. So we had left off, we were talking about sort of schizophrenia and things that might be causing it, things that might be related to developing it, how we can treat it, and what we tend to observe in people who have it. And we had left off on a couple of these graphs, so I did some reading up in between so that we can talk about these. Even though I didn't include the details of this on the slides, this graph was just showing that there seems to be a correlation between mothers who have exposure to influenza while they're pregnant and their children having schizophrenia later in life. Which is really, really interesting. Yeah, so I did quite a bit of looking into this because when they were talking about schizophrenia as a developmental disease, that was their sort of little tie-in to the fact that, yeah, they have, so they have sort of healthy volunteers, so looking for no exposure, so that interleukin is just sort of an indicator of antibodies in response to influenza. So the idea is that maybe it's not necessarily influenza itself, but it's exposure to the intense immune response to having influenza. Though they haven't been able to find like a causal link, they've just found that there tends to be a higher rate in those who then develop schizophrenia. So that's interesting. I'm like, that's fairly recent, I guess 10 years old, but it'd be interesting to see if they find any follow-ups on that. And then this one was, and this was just showing that they tend to see higher incidences of schizophrenia in years that have more extreme years of influenza. So the more exposure to those things, then the more likely it is to develop schizophrenia in the future, which is very, very interesting. So it seems to be something that sort of affects you from birth or even before birth, and then doesn't necessarily show up until much later. Though there have been some studies that started looking at, say, behavioral data. Specifically, they looked at home videos of those who were later diagnosed with schizophrenia, and as children, they showed some behavioral deficits. So different types of responses, different kinds of facial reactions, that sort of thing. So there seems to be some kind of developmental link there. But as I said last time, a lot of this is still very speculative, and it's not necessarily concrete quite yet. All right, so next we're going to be talking about affective disorders. So we spent an entire class on schizophrenia, and then all of the other disorders we're going to sort of chop down and cover a lot more briefly, just because we don't have time for all of them. But also, schizophrenia is one of the most widely studied, at least in terms of genetic bases and environmental influences. It was one of the first genetic studies, because I showed you those family studies that happened years and years ago. So even before it was possible to do DNA testing, they were still doing genetic-based research by looking at heritability. So hence the wide range of things we can talk about related to schizophrenia. But everything else is going to be a little bit less extensively studied, but equally interesting. And so we're going to be looking at a category called affective disorders. And here, affect is referring to mood. So these are mood disorders, and you might see them called sort of one or the other. So the three major categories are depressive disorders, mania, and bipolar disorders. And so depressive disorders are going to be sort of an intense sadness and loss of interest, or sort of lack of compassion or interaction with things. Mania is sort of the other end of the spectrum with excessive energy and usually increased confidence. And then bipolar disorders actually alternate between the two, at least to some degree. And so we're going to go into each of these on their own. So for our depressive disorders, the text makes it clear that we all typically experience at least a little bit of what's called reactive depression, which would be occasional intense sadness in response to life's challenges. So if we encounter a really difficult situation, if we suffer the loss of a loved one, it's not uncommon to experience reactive depression, meaning depression that has a traceable source to some event in your life. But mostly we're going to be focusing in on major or unipolar depressive disorder, or MDD. So usually you're going to see it called major depressive disorder. They specify unipolar simply because they consider it along with bipolar, where unipolar would be sort of just the depression side of the scale, and bipolar is that depression mania cycle. And you find that a lot of these terms are going to change pretty dramatically over time. I find it very difficult to keep up with what the proper terms are at any given time because, as I've mentioned, there's a lot of overhauls to that DSM, and sometimes these are called slightly different things only a few years previously. So just something to keep in mind if some of the terms don't quite ring a bell. But when we're talking about major depressive disorder, this is when you have depression or intense sadness and that loss of interest, but it lasts for very long periods of time. In order for it to be classified as major depressive disorder, it has to occur for weeks on end, but it can occur for months or even years at a time. And so you might talk about a major depressive episode being a sort of long period of being depressed. But you'd have to have sort of a couple of those in order to classify, or long term of those to classify for major depressive disorder. All right, and then mania is going to be sort of a whole bunch of different symptoms, and in order to get the diagnosis of mania, you would have to have 3 or more of these somewhat scattered symptoms here. So it may cause inflated self-esteem, decreased sleep, which kind of makes sense with that increased energy, talkativeness, racing thoughts or ideas, easily distracted, increased goal-directed activities, needing to accomplish absolutely everything all at once, agitation, and excessive involvement in risky activities. So for that one, we occasionally see people who have sort of a loss of risk aversion. So typically, people don't like to do things that might be risky. But with mania, you kind of lose that inhibition, and you might be willing to engage in those risky activities a lot longer. And so this disorder typically comes with lots of energy, like I said, lots of confidence, and it typically leads, or it can lead, I guess, to grandiose schemes. So thinking highly of yourself and then not having those inhibitions can lead you to acting out on these sort of feelings. And we have to, like, some of these things, so decreased sleep and increased talkativeness, well, you might just be excited about something, and decreased sleep could be you're just a student. So they have this sort of specialization or specifying that this disorder has to be debilitating. So it can't just be that, oh yeah, occasionally I talk too much. It has to be talkativeness to the point of causing problems for yourself or others. And it cannot be caused by drugs, because a lot of these would overlap with the symptoms of taking recreational drugs. And mania on its own, so just having mania as is actually fairly rare. Typically, people will experience it as part of bipolar disorders where they cycle between mania and depression. So it's much rarer to see it just as mania and then returning to normal for periods of time. It's usually mania and then periods of depression. All right, and that brings us, of course, to bipolar disorder. And so this is, like I said, you alternate between periods of depression and mania. And they differentiate between two different types of bipolar disorder. So bipolar 1 versus bipolar 2. And bipolar 1 is depression to full-blown mania, so very intense symptoms of mania. And then bipolar 2 would be depression and hypomania, which is sort of less intensive spurts of mania. So a little bit less debilitating on that side of the scale. And interestingly, it seems that bipolar disorder is kind of like a bridge between depression and schizophrenia. So the depression being that low energy, and then schizophrenia, at least positive schizophrenia symptoms, being sort of too much of something. So some of these mania symptoms can be very, very close in appearance to schizophrenia. So it's that alternating quality that helps us tell them apart. And especially with bipolar 1, which is the more severe version, patients will also have psychotic features that make it very, again, similar to schizophrenia. Things like delusions and hallucinations and paranoia and other bizarre behaviors, hence them being fairly similar. And then there's a third category that we don't really touch on that much, and it's called cyclothymic disorder. And it's just a very, very quick cycle between mild mania and mild depression. So it's like the least severe case. So you don't have overly debilitating versions of either, but you still do cycle between highs and lows pretty frequently. All right. And so with bipolar and the related disorders, so all of these sort of in the categories around it, we see tons and tons of variability in these symptoms. So those mania depression cycles, they might be really, really rapid. So some people might cycle on like sort of a day or two basis, and some people might cycle over months. So we see tons of variability there. And usually the depressive side of the cycle is the predominant one, but not always. Sometimes people will have the mania be the one that lasts for longer. Or you might have them both be equal. Just it's more common for the depression side to be more heavily weighted. All right, and so mostly they think that this is due to, or at least it's interfered with by stress. So stress can trigger a transition from depression to mania. And if you're stressed, you can then also have sort of a transition from mania back into depression. So stress seems to be involved in that cycle, theoretically. But as individuals have this disorder for longer and as it gets more and more severe, those switches will start happening regardless of stressors. It isn't as tied to life stressors. So early on, when it's less severe, it's going to be something that you can kind of manage by sort of removing stressors from your life and just being aware of what causes stress. But over time, it becomes sort of something that's out of your control. Oh, yep.
Most people with bipolar disorder have to be treated with like chemical treatment or like therapy treatment?
If it's severe enough to cause disruption to their lives, yes. And we don't talk about it too much in this course, but it's actually really problematic because between sort of the ups and downs, it's hard to get someone with bipolar disorder to commit to medication. And especially when some days they feel like on top of the world and then other days too low, it's really hard for consistency there because maybe they feel so good that they don't want their medication, but then not being medicated cycles them back down again. And then when they're depressed, it's really hard to start medication. So a lot of these disorders end up kind of interfering with their own treatment plans, which is really difficult. Yeah. And we have, again, a lot of this vagueness of they're not quite sure what's driving it, but maybe it's due to increased sensitivity to dopamine or decreased sensitivity to serotonin, or maybe it's some general dysregulation of that dopaminergic system. So they're not quite sure what's going on, but it's something to do with the levels of different neurotransmitters in the brain not working optimally. And so they use some second generation antipsychotics. So we mentioned some of these in our discussion of schizophrenia, where the first generation antipsychotics tended to sort of, some people didn't respond to them at all, and they had that risk of developing severe tremors and side effects if you took them for too long, and they could lead to sort of neural damage. The second generation antipsychotics are going to do the same thing, just a little bit less effectively, but without that associated risk. And so they can help with schizophrenia, but they can also help with bipolar and other disorders in that area. Again, probably due to that dopamine dysregulation. Lithium is another really common treatment for bipolar disorder. And so it's an element, and they typically deliver it in the form of lithium carbonate, just so that it's stable and bioavailable. And that's sort of the most common form of treatment. And then the last ones are carbamazepine and valproate, which you won't have to remember those specific names, but they're basically anticonvulsants, and they help to stabilize some of the weird electrical activity in the brain. So we find with a lot of these different drug treatments, most of them, we don't really understand them very well. A lot of treatments for mental disorders are actually sort of trial and error, where they have a vague idea that maybe it's due to this. And that's why you find a lot of variability in effectiveness and things like that. All right. We don't need the specifics of those mechanisms. Okay. And then if we wanted to look at the heredity of these affective disorders, we are again going to see that, yeah, there is at least some genetic component. And just like with schizophrenia, we can't point to one specific gene or even a specific set of genes. But we do see that there's fairly high concordance between identical twins, and that number drops off between fraternal twins, meaning that those that are more genetically related are more likely to both have the disorder. And as that genetic relatedness drops off, so does the chances of both having the disorder. So any kind of environmental aspect of this, so if we're thinking of our diathesis stress model or or a vulnerability model, the environmental component is just general stress. So life stresses of any kind can contribute to your likelihood of developing this. And interestingly, so we've commented on the fact that bipolar disorder and schizophrenia are fairly close to each other in the way that they behave and even the way that they're treated. And interestingly, when they started looking at, okay, well, bipolar seems to be right between schizophrenia and depression, so maybe it's similar to depression as well. But in fact, it's actually very different from depression, and it seems to be genetically independent. So it might just be a depression from a different source or something else entirely. But I guess it would be hard, because usually for these things, if you're looking at relatedness, you might look at co-occurrence, and it's hard to tell them apart, but at least like they don't see that in families where people tend to have bipolar disorder, there isn't also an increased likelihood for them to have depression. It's if they have bipolar in the family, then it's likely to be bipolar disorder. And if you have depression in the family, it's more likely to be depression. Yep. Probably. So the way that I look at it is when we're looking at our family studies, so we see similarities probably because there's a mutation or a set of mutations that have caused this imbalance. And so to have both of them, if they're genetically dissimilar, you'd have to have two mutations in two different places, which isn't impossible, but it's more unlikely. So if you're very, very unlucky, you might have two individuals who maybe someone marries into the family and brings in that gene. You could then have an overlap, but statistically speaking, it's very unlikely, but not impossible. And I guess it's harder to document because we don't do a ton of those type of family studies. There's really only the big ones in Ireland is big, and I think Iceland does one as well, just because of that lack of immigration and emigration. But yeah, theoretically, yes. Okay. And so if we wanted to talk about some hypotheses for not just bipolar disorder, if we want to talk about depression, they think that it might be due to this monoamine. So the monoamine hypothesis says that depression probably involves reduced activity at norepinephrine and serotonin synapses. It's interesting here to note that dopamine is also a monoamine. So dopamine, norepinephrine, and serotonin are all monoamines. But like we said, depression seems to have a different root cause from either schizophrenia or bipolar disorder. And so it seems to involve monoamines that are not dopamine, which is why they think that it's very genetically dissimilar. But there is a little bit of a blur where some things that affect dopamine can help with depression, but they don't quite know what the mechanism is for that. Again, we're into a lot of, we don't quite know what's going on here. But if we have any effective antidepressant drug treatments, they're typically going to be increasing activity of either norepinephrine or serotonin or both at the synapse. So if we're having reduced activity, then maybe they're going to increase the production of, or increase the sensitivity to, or increase the number of receptors for one of those neurotransmitters. And so when they talk about these sort of different categories of neurotransmitters, they're usually focusing on one of those mechanisms. So they'll group them by, actually, I think I wrote it down so I don't forget them. There we go. So our monoamine oxidase inhibitors, actually just from the name, so ASE, that ending, indicates that something is an enzyme, so it's going to break something down. So if this is inhibiting monoamine oxidases, it means that this class of drugs are going to stop the breakdown of existing monoamines. So basically it says that when they've been dumped out into the synapse, instead of degrading them and recycling them, it's going to keep them around longer, making them more effective for a longer period of time. Our tricyclic antidepressants are going to block reuptake, so another mechanism for keeping them from being pulled back out of the synapse. So instead of preventing the degradation, it just prevents that cleanup process. So reuptake is when we pull it back into that presynaptic neuron and restore them in the vesicles for use later. We would just leave them in the synapse longer, and again, increasing activity. And then the atypical antidepressants, those are our second generation antidepressants. And these are typically going to focus in on either norepinephrine or serotonin with just a little bit more precision. But these are sort of a big category of everything else. So they're going to be, so things like Prozac would fit in here, and also our selective serotonin reuptake inhibitors. So if you've ever heard of SSRIs, they'd fall under those atypical antidepressants. And so they focus in on serotonin, and from the names, they're going to sort of inhibit the reuptake of serotonin, so leaving it specifically in those synapses for longer. All right, and so there's all sorts of other ones that can fall in there, but we've hit the major categories. All right, for other types of treatments, another very controversial one is using electroconvulsive therapy, or ECT. And so typically when we think of electroconvulsive therapy, we think of mental institutions back in the 1950s when they didn't have great regulations and they used all sorts of strange and ineffective types of treatments. But in fact, ECT is fairly effective at treating things like depression when used properly. So there's a lot of ethical considerations here. And so we see the application of a mild voltage of electricity to the head. Nowadays, patients would be anesthetized, so it's not as traumatic or painful or frightening as it used to be. And it's intentionally producing a seizure that's going to last for about a minute, up to a minute long. And this seizure activity maybe is resetting some of those pathways in the brain. We're going to find, as I have on the next slide, of how do these treatments work, we're not quite sure. And when we're delivering this ECT, it's usually done a couple of times a week over a long period of time. So this is something where you're trying to sort of change the patterns of firing in the brain to sort of get away from those abnormal patterns that are causing issues and get back to sort of quote unquote normal levels. And you can use bilateral, meaning both hemispheres, or unilateral, just one side, depending on which areas of the brain are showing overactivity. And because of all of the ethical concerns and a lot of sort of issues with, maybe this is a more extreme treatment than needed, this is only done in patients who don't respond to or cannot take medications. So this is one of those last-ditch efforts. If they've tried everything else, then this is what they might go to. And I don't know if I end up mentioning it, but there are some really interesting studies about sort of specific targeted electrical stimulation. So treatment for things like Parkinson's disease, deep brain stimulation can be very useful. This would be more surface level, but the same basic concept. And there's also some recent work that I was looking at where they use that transcranial magnetic stimulation, and by applying magnetic currents to different parts of the brain, again, sort of multiple times a week over long periods of time, can also help with depression. And that's starting to become a much more common approach than ECT, just because it's non-invasive and it doesn't produce seizures or anything like that. But that is very cutting edge. I think that was a popular science article that popped up for me fairly recently. So don't think that one's in the textbooks quite yet. All right. And so then we get to this, how do the treatments work? And I was going to do sort of a summary of all of it. And the big take-home message was they're really not sure. As I mentioned before, a lot of these things are, well, we think that dopamine is involved. And why do they think dopamine's involved? Because drugs that change the functioning of dopamine seem to help. They don't know why or how, but it helps. Therefore, it must be due to dopamine. And that's the kind of logic that we see for a lot of these disorders. So a lot of psychological disorders, our understanding of how they work is fairly vague because our theories are coming from, well, this drug happens to have this effect and it seems to help, therefore it must be due to this. So there's a lot of things that we need to keep in mind. We might think about some of the weird things. So with antidepressant drugs, so we have these antidepressant drugs, and as soon as they're in our systems, they actually do change our neurotransmitter levels very, very quickly. But there's a long delay period. So if you've ever had to take antidepressants, there's actually a 2 to 4, maybe even 6 week period in which they're not effective. And that's not because they're not affecting your neurotransmitters, but it's because the effects of those changes don't trickle down until much later. And again, they really don't know why. The delay seems to be fairly consistent across multiple kinds of medications, and yet they're not quite sure what the mechanism is there. So one theory is that maybe it's affecting sort of neuron growth rates. So maybe we're producing more neurons, so we have to wait for the new neurons to come into effect. But we can only have neuronal growth in very specific areas. So I think the hippocampus is one area that they think it might be happening in, but we don't see a ton of neurogenesis in adult brains. So maybe that's what's going on. That's their leading theory. But as we see more neurons being created and more connections forming, we also see more cell death as well. So it's not like there's a net increase in number of cells or not a massive net increase. It's just that we see a little bit of turnover rate. And so the idea is maybe the new cells have more flexibility because they're new. So we have increased plasticity, which can help with some of these issues. Maybe. And because of this sort of changes in the neurons that are present and the connections they're forming, some antidepressants might be sort of causing this dendritic remodeling and changing our synapse contacts. So it's maybe moving around some of these pathways. So it might just be that while they're present, they're changing the brain shape. And so maybe it's more of a increased plasticity and increase in connections rather than a big focus on more neurons that are being created. But again, big take home is this is all very theoretical. So we're going to move into our next category, and these are rhythm and affective disorders. And so this is when we start looking at either seasonal or daily rhythms. So our bodies have fairly natural rhythmic cycles. So we see cycles daily, so our circadian rhythms, so the cycle between being awake and being asleep. We see changes in our neurotransmitters, our circulating melatonin levels, even our body temperature cycles will be warmer during the day and cooler at night by almost a couple of degrees. And so there's lots and lots of things that cycle that way, hormones as well. We can also have monthly cycles, especially in women. We tend to see sort of hormone cycles that go every 28 days or so. We also have seasonal cycles. Those seem to be more externally driven than internally driven. So our seasonal cycles are mostly driven by light levels and sort of the temperature and things like that. But we have tons and tons of these rhythmic practices within our bodies that are controlled by lots of different factors. But our circadian rhythm can be affected or it can be changed a little bit by some of these affective disorders. So we can see phase advance in patients with different affective disorders, which is basically the idea that a person feels sleepy earlier and then wakes up earlier as well. So it's kind of like we have sort of normal cycling levels of melatonin, and this is more than what you need to know, but there are a whole bunch of genes that are related to these circadian rhythms. Most of them are called clock genes because they create cycles, and they have built-in buffers so that we cycle even if we're not exposed to daylight. And so, in fact, you can have people in complete darkness who will still have circadian rhythms. There's a little bit of drift because they're not exactly 24 hours, but it still happens. And so what happens in these individuals is that those cycles are offset. So they're still 24 hours, but when they're supposed to be starting, so their day starts earlier than it should. So they wake up before the signals that they're using to sort of reset, because we can use light levels to reset our circadian rhythms. They're just waking up earlier than they should. So they have that advancement of their cycle. We can also see issues with rapid eye movement sleep or REM sleep disorders. So REM sleep is the stage of sleep where we do a lot of our dreaming, not all of our dreaming, but a good chunk of it, and it's associated with rapid eye movements. And individuals with affective disorders also typically lose out on other stages of sleep and overdo the REM sleep. So I think we talk about sleep possibly the next chapter. I'm not quite sure if we even go over it. I can't remember the numbers for this course, but with REM sleep, that's sort of you cycle down from sort of light sleep, sort of deeper sleep, deepest sleep, and that's sort of that recuperative sleep when you start recovering. And then you sort of go back up into light sleep, but instead of staying at light sleep, you hop up into REM sleep, and your brain activity is very close to while you're awake. And so maybe you're processing things that you experienced during the day. Maybe your brain is just active and resetting. We're not quite sure. And then you'll cycle back down into deep sleep and up and back down and up and down. So that's our cycles while we sleep. And so here they're saying, okay, so we're going to be biasing our sleep towards REM sleep, which means we spend less time in those deep recuperative states. And it can actually affect your behavior outside of sleep because we need that deep sleep in order to recover and feel rested. So if we lose out on it, we can have sort of issues the next day. All right. Another cyclical disorder that's related to our affect is seasonal affective disorder, or SAD. And this is a pattern of depression that follows our seasons. So a circannual, there we go, rhythm, where, so basically in the winter when it's darker and colder and you see less light, people are more likely to be depressed. And the reason why they assume that this is tied just to sort of light levels is because it happens over longer periods of time in sort of higher latitudes, I believe. And so in Edmonton, where our days are very, very short in the winter, seasonal affective disorder is really common. I have a friend who works up in Alert, which is a sort of government base to the point where the sun doesn't actually rise in the winter. And they have to have a therapist on site along with any researchers because this can be such a problem. And so they have to be aware of this because it can cause massive sort of mood declines. And so they might have treatments like phototherapy where they get patients to sit in front of high intensity lights for a couple of hours a day. And that can kind of help reset our system. Exposure to the sunlight might make us feel better. Yep.
This is more just of a comment, but something that's really cool that Concordia does is that you can actually rent those types of lights from the library and just like take them home and use them.
That's really interesting. Yeah. I didn't know that, but that's such a good idea because like the more northern you are, the more of a problem this becomes. And in my genetics and behavior course, I get to look at sort of some of the genes that might be involved in this. And we actually look at studies that took latitude into effect. And it was really interesting to see that, yeah, it's way more severe the further north you get. And it's consistent not just in North America, but also in Europe and basically everywhere. So it is a pretty big thing, and it's only recently that we've started talking about it, but it's been a big thing for a really long time. Yeah, and then so this that depressive side of things during the winter can lead to things like excessive sleep, increased appetite. So when people talk about sort of putting on weight for the winter, it might actually be part of seasonal affective disorder. And there are some really rare cases where some individuals have almost reverse seasonal affective disorder, where in the winter, when sort of the days are shorter, they actually feel better. And they feel worse in the summer when the days are longer. And I'm not sure if that's just a genetic thing or what, but it's so rare that they probably haven't studied it a whole heck of a lot quite yet. So that might be more related to temperature rather than the light levels, but they're, again, not quite sure. All right, and then into our neurological anomalies. So with depression, we see lots of prefrontal deficits. So we'll get a reduced total brain activity in unipolar or depression patients, but also when bipolar patients are in that depressed cycle. So the depression side of things seems to be involved with this sort of reduced overall brain activity, and some areas, despite the sort of overall trend of downward, less activity, some areas then overactivate. So we see the areas responsible for attention and filtering information tend to be overactive. And so this might lead us to be unable to focus on things. There we go. And so we can see things like, okay, we can't filter this information. That part of the brain is too active. It can't do its job. Or maybe we're focusing on everything all at once and it's overwhelming us and making us shut down. So it can start impairing some of our decision making. It can even affect our judgment. So that's a pretty big thing. And so we'll see increased activity in the amygdala, which is related to emotions, and the ventral prefrontal cortex, so making connections and filtering information. For bipolar disorder on its own, we'll see a decrease in thickness in the cortex, and we'll see a decrease in glial density. So basically just a reduction in volume there. So maybe, okay, so there's less neurons in the amygdala as well. So that kind of makes sense if their amygdala is related to emotion. If we're seeing fewer neurons or less density of neurons, they're sort of unconnecting to things. That could make sense. Some decreases in the prefrontal cortex overlapping with our just depression on its own. Reduced connectivity in the cortex, so the outer layer of the brain, the corpus callosum, the bridge between areas, and then the thalamus, sort of one of our connection areas. So a lot of this is decreases and reduced connectivity and fewer neurons, or at least reduced volume, which implies fewer connections. So it might make sense if bipolar disorder is sort of this cycling from too much to too little and back again. If we don't have these connections, maybe we're having trouble with regulating things. So maybe we're shifting between too much and too little because we can't find that balance in the center. We're having trouble maintaining homeostasis for mood. We do see increases in brain metabolism during manic episodes, and then that decrease in brain activity overall in those depressive episodes. So again, lack of overall regulation here. All right. And then very briefly at the end of this, they do talk a little bit about suicide and suicide rates. And this is another one that has some interesting statistics of newer research. So suicide rates are fairly high, especially in sort of younger age brackets, and they have been showing an increase in trend, but they've actually found very, very recently, sort of on the preliminary data, during the pandemic, they had reduced suicide rates. So they're showing a 3% reduction in suicides in 2020, which doing some critical thinking on those articles, it might actually be not so much an actual decrease, but it might be a methodological decrease where a lot of things haven't been processed because of the pandemic. So there are a lot of people who have died who haven't been sort of entered into the system or who haven't been classified as certain causes of death. So that might be possible. But even in those studies, if you dig into their data and break it down based on sort of age groups, we still see that higher trend and increasing trend in that sort of 15 to 29 year bracket. So exactly our age range tends to sit right around there. So it'll be interesting to see the studies that come out of that. And there's a really high co-occurrence of suicide and psychiatric diagnoses. So about 90% of those who have attempted suicide have some diagnosable psychiatric illness. Whether they were diagnosed at the time, they just have some traits that could qualify them for diagnosis. And there's also genes that might have sort of links to suicide. So there might be some neurological pathways that predispose people to this. If you sort of think about it, there might be cases where it runs in the family, and that could be because of that genetic component. But again, not super well studied just quite yet. All right. So our next category is looking at anxiety, trauma, and stress-related disorders. And you're going to find that as we're going on in topics, we're going to spend less and less time on each of them. And that is intentional, and it's also going to keep us on time today. So in these anxiety, trauma, and stress-related disorders, we again have this heritability. So we see between 30 and 50% heritability, and it's going to vary between the disorders, but overall, again, yes, we do see some of this genetic component. We're also going to see some environmental component. It's kind of the same thing over and over again. We do see that antidepressants can be effective for treating both those mood or affective disorders and anxiety disorders. And we're going to find that a lot of individuals who have depression also tend to have anxiety. So there's some concept of maybe there's some neural commonality, maybe it's two sides of the same coin. There's sort of this idea that anxiety is sort of the overactivity side of things, and then depression is the underactivity side of things, kind of like a less extreme version of bipolar disorder. So there's some ideas of that, perhaps. And when we look at this heredity, when we look at these genetic underlying factors, when we've done sort of larger scale tests, because it's become possible now that we can do full genome sequencing, we can actually look at, okay, how does this break down? Where do we see mutations? Where do we see similar genes? Where do we see similar things among people who have X, Y, or Z disorders? And we see that there are genetic clusters for generalized anxiety, panic, and agoraphobia. Those all seem to involve the same gene areas. We also see animal and situational phobias having their own locations separate from the others. And then social phobia end up actually overlapping with both. So it's not its own distinct category, but it's a bit of both, which seems to be a little bit of our trend today, where we talk about two extremes and then the thing in the middle. But these are just looking at sort of what genes might be involved, and so they can pull out particular, they've probably narrowed it down to different arms on particular chromosomes, saying that there's something here. But again, it's very difficult to get a particular gene, and it's usually multiple genes, maybe in the same area, maybe not. All right, and so if we wanted to focus in, we need to know that anxiety is not just fear. So fear is typically, when we're talking about it, sort of a response to something in your environment. And fear is usually going to be justified. So someone jumps out at you and startles you, that would produce fear because it was sudden and it activated that part of your nervous system, logically. But anxiety is when you have this anticipatory state, so you're constantly on edge waiting to be afraid, or you have overreactions to things in the environment. So if somebody jumped out and spooked you and you just never calmed down afterwards, that could be classified in anxiety because it's a disproportionate response. And so if we talk about our generalized anxiety, that's feeling stress and unease most of the time. So long-term exposure. And again, there's no legitimate or no sort of viable environmental source for that. So if you're feeling anxious, but you're also trying to study for 4 different midterms at the same time, that's understandable. We wouldn't call that generalized anxiety. We would call that being a student. But when you have sort of no reason for that anxiety, and when it's sort of all the time in all places, that would be generalized anxiety. And we see people in those, or with that, overreact to stressful conditions. So someone with generalized anxiety who then had to prepare for a bunch of midterms might disproportionately react to it. So instead of just being like, oh man, I gotta buckle down, they might sort of go into full anxiety mode. Panic disorders are when individuals experience sudden and intense anxiety attacks. And there is a distinction between anxiety attacks and panic attacks, sort of one being a more extreme version of the other, but that's, I guess, beyond what we need to know for here. We can talk about phobias, where individuals experience fear or stress when confronted with a particular situation. So anything that or any word that ends with phobia is usually describing a phobia of a particular thing. So agoraphobia, the fear of going out in the open. Choleraphobia, I don't know why I always remember that one, is the fear of clowns. Arachnophobia, fear of spiders, and so on and so forth. They've come up with names for all sorts of types of phobias. We can also very briefly talk about post-traumatic stress disorder, or PTSD. And this is a prolonged stress reaction that's caused by a traumatic event. And if you go into more detail on the diagnosis of PTSD, they actually differentiate between PTSD caused by physical situations and caused by sort of non-physical traumas. So there's complex PTSD as well, but the sort of outcome of it are typically fairly similar. It's just a little bit harder to diagnose because they can't point to one specific event or a series of events that caused it. And this is typically characterized by flashbacks, where you have sort of recurrent thoughts and images of the traumatic event that led to the disorder, avoiding anything that reminds you of that event, feeling empty or detached, so unable to connect, lack of concentration, so inability to focus. That's probably due to the fact that your body is in fight or flight mode all the time. So you're paying attention to everything and therefore can't focus on one thing. And because you're in that mode, you're probably going to overreact to environmental stimuli because you're constantly waiting to either fight or flee. And so that's another really complex disorder there. In a lot of these are sort of tied to anxiety and fear. So of course, our amygdala is over-responsive. So we have very high levels of activity in the amygdala, which seems to be across all of these different disorders. We also see hyperactivity in our cingulate cortex. And this is for general anxiety, panic disorders, and phobias. So again, that's probably due to regulating emotions and maybe not doing the best job of it. And then our insular cortex is going to be overly responsive for phobias and PTSD. So we find that phobias kind of overlap with the two of them, and that's probably, again, because we have some maybe genetic similarities between some of them. But PTSD would have different sort of brain functioning anomalies than generalized anxiety. So some similarities, but also some differences. All right, and then continuing on with our very brief discussion of these topics, we can get into personality disorders. And so with our behavioral patterns for personality disorders, we see things like distrust and suspicion, unstable social relationships, problems with control and attention, and emotional dysfunctions. And so the reason why all of these terms are so vague is because personality disorders is sort of the general term for 10 different related disorders that are all kind of tied together by these commonalities. And so we just see this trouble regulating their emotions, issues with control, either sort of too much or too little, need for attention or not wanting attention, and so on. So there's lots of variability here. We're also going to focus in briefly on obsessive compulsive disorder, or OCD, where obsessions are recurring uncontrollable thoughts, and compulsions are ritualistic behaviors that are done in order to remove the anxiety that's associated with an obsession. So typically that uncontrollable thought will keep cycling in your brain, and then you get an urge to do a particular behavior so that something bad doesn't happen. And then doing that behavior makes you feel better. But if we think about learning, that would be reinforcement. So because the bad feeling went away, you're now more likely to engage in that compulsion in the future. And so it can get more and more intense as time goes on just through learning. And for this, we see increased activity in our orbitofrontal cortex, and specifically our left orbital gyrus and the caudate nuclei. I'd more care about the orbitofrontal cortex, so this sort of area. And this is another one of those, they think that patients with OCD have high serotonergic activity, so high levels of serotonin, but that would be, again, because it seems to respond to drugs that affect that, rather than actually having a particular pathway that they can agree on. There are some disorders that are related to OCD, so this being more sort of repetitive behaviors and those compulsions to keep doing them. So things like over-grooming. These aren't just common in humans. We also see them in, say, stressed parrots. Cats will do this as well. Lots of pets, if they don't have enough stimulation, they'll engage in over-grooming. So parrots will pluck, cats will sort of lick until their fur goes away. In humans, we can see it as nail biting, hair pulling, and skin picking. So these are just, again, sort of repetitive behaviors that people don't realize that they're doing. And then hoarding would be sort of overlapping a little bit with OCD. Some people who have OCD are also hoarders. And we see that hoarders have more activity in their insula and the AAC. So the idea here is that they basically have trouble assigning value to things. So they will hoard items that are not valuable, that should be thrown out, things like newspapers and egg cartons. But their minds have a lot of trouble realizing that, yes, that's worthless, I can get rid of it. So instead, they assign value to everything and then can't throw them out. So that's what they think is going on there. Tourette's syndrome is also grouped in here just because of the repetition of the behaviors. So Tourette's syndrome is when individuals produce a variety of motor and phonic sounds, or sort of tics. So phonic being sound tics, motor being sort of movement tics, and they might have one or the other or both. And symptoms usually start fairly young, and they start simple and then get more complex over time. And there seems to be some compulsive aspects to it, so maybe it's sort of like OCD, and doing these behaviors sort of makes you feel better briefly, so it might lead to it happening more often, but it doesn't seem to have the same level of awareness and cognitive decision to do so. And individuals with Tourette's syndrome can suppress these tics for short periods of time, but doing so is very mentally taxing and can actually lead to increased rates of tics after they stop suppressing. So if they suppress while they're at work, when they get home, they're a lot more likely to have outbursts. And that can be really draining because of all of the extra mental activity of doing that. All right, and then our last topic is borderline personality disorder. Oh, I didn't change my notes. There we go. And this is another one that has a bunch of possible symptoms or a bunch of characteristics that we might see. So individuals with BPD might have unstable interpersonal relationships. They may have poor self-image. They're typically impulsive. They have an intense fear of abandonment and rejection. So a lot of their behaviors are done with the intention of keeping people close to them. They have a strong desire to be loved, which can lead to sort of manipulating people to stay close and to think highly of them. And they're going to cycle very, very quickly between feelings of love and hate. So as long as they are being sort of, if someone goes along with them, they're fine. But if somebody sort of goes against them, makes them feel unloved, then they would sort of swing to the other range of the spectrum. And this comes along with increase in risky behaviors, yet again. So things like gambling and speeding, unprotected sex, all those things that we might think better of if we had sort of properly functioning ability to evaluate risks and outcomes, but they do not. And then also they have high risk of suicide and suicidal thoughts, probably because of all of those negative internalized cycles that we mentioned above. So up to sort of, there's a variance, sort of 8 to 10% of individuals who have BPD will end up killing themselves. And usually they do it through overdose of medication. So it seems to be a pattern where a lot of them will go the same route. And it has a very strong genetic basis. So we see around 40% heritability. So we do see this as another thing that would run in families. And I'm not going to go too much into sort of the causes of it, because we have enough of those this time around. But it seems to be maybe, okay, so we have some serotonin and some dopamine dysregulation. So same as a lot of the other ones we've talked about. Yeah. And I think that's good enough there. I have, like, with the notes, I was like, I included some of the details, but we don't need all of that. We can keep it at that point, and we'll sort of stick to the high end of stuff. And yeah, so we're a little bit early. So like I said, if you wanted to take a look at your